So my name is Dr. Arinze Ikeme. I am a nephrologist here in North Carolina. I am also an associate professor with one of the medical schools in the area. I teach medical students. I also teach nurse practitioners, physician assistants, and also tutor new physicians who are just completing their residency program and are interested in, taking up the inpatient hospitalist medicine. So today I'm going to give a brief introduction to hospital medicine, both for the medical students, just to see what it's like, for nurse practitioners, physician assistants, and new physicians. Again, just to see the structure and how we navigate hospital medicine. I'm going to go through the outline. I'll give us a brief idea on what happens in the ER during the evaluation and triage. We'll go through, we'll dive into the stages of inpatient management, establishing diagnoses, coming up with treatment plan and implementation, troubleshooting while they're in the hospital, and determining the patient's readiness for discharge and disposition plan. And then I'll give us a managed summary. For the emergency room evaluations and triage, this is typical in every emergency room. The patient comes in with some symptoms. The ER provider gets a history and physical exam. Based on their findings, they order directed lab tests and imaging, initiates patient management, stabilize patients who need to be stabilized, and then they triage the patient. The triage is to determine whether the patient can be managed as an outpatient, so discharged from the ER, or if they need to be admitted in the hospital, either as an overnight observation or inpatient admission. And that's where we come in, really. Some of the factors that will determine the triage for the patients will be if it's a life-threatening condition, if there is hemodynamic instability, need for further evaluation or monitoring, need for intravenous medications, inability to tolerate oral medications, especially for those coming in with nausea and vomiting. And if there is lack of social support or they don't have a primary care physician, these are things that they would have to consider in determining who they can manage as an outpatient or who will be managed in the hospital. And again, the Medicare, CMS, and insurance companies also have their own criteria on who qualifies for outpatient or inpatient management. So, what are the stages of inpatient management where we come in? What do we do really when a patient is being admitted or we've been called by the ER to admit a patient? So, stage one, the first thing we want to do is establish a diagnosis. Now, even though the ER attempts to establish a diagnosis, we still do our own evaluation just to make sure that we are in agreement with the ER provider diagnosis. So we take our own history and physical examination. And we never forget to start with the open-ended question: what brings you to the hospital today? Symptoms can suggest a particular system involved and would guide your physical examination so that you have some differential diagnosis. For instance, if someone comes in with nausea, vomiting, abdominal pain, my first impression will be a gastrointestinal issue, or an abdominal issue, which means it could be a pancreatitis, it could be a cholecystitis, which is gallbladder inflammation, could be a bowel obstruction, and that helps guide my examination. So when I examine this patient, my abdominal exam would need to be real thorough to help me generate, differential diagnosis, and that will lead me to the next step, which is my lab test. It needs to be focused on establishing a diagnosis, and so you avoid unnecessary lab tests. For instance, with nausea, vomiting, abdominal pain, I would want to get the CBC, I would want to get the chemistry panel, I would want to get maybe a lipase level, liver function test, urinalysis, and of course, order some imaging. If there are red flags like abdominal pain, hemodynamic instability, elevated WBC, then we can get a CT scan to know exactly what's going on in the abdomen. Now, once we've done this, at this point, by the time you're done with the images and the labs, you should have established a tentative diagnosis. And then you move to stage two, which is your treatment plan and implementation. Now, there are cases that will need further evaluation, like, stress test, MRI, echo, getting a specialty involved, like, the gastroenterologist or the cardiologist. But your treatment plan are twofold. You need your definitive treatment and your supportive management. For your definitive treatment, it might be antibiotics for infections, diuretics for heart failure treatment, breathing treatment for asthma or COPD exacerbations, etc. And of course, your supportive management, if they need oxygen or IV fluids or antiemetics or electrolyte replacements or blood transfusions or pressors, you want to make sure you don't forget the supportive management. That moves you to stage 3. Now, stage 3 is about troubleshooting. Now, it's not unusual. You have a tentative diagnosis and you start treating the patient and they are getting worse. You would have to learn how to troubleshoot in those cases. And some of the reasons why you might need to troubleshoot might be patients who are getting worse despite your treatment, or they might develop complications from the primary diagnosis, like bowel perforation if you're treating acute diverticulitis or ARDS while treating pneumonia. And your initial diagnosis might be wrong, and you might need to revisit that again. And occasionally, new unrelated issues come up while they're on admission, like their heart failure might start acting up while you're treating cellulitis because of fluids given, etc. So you should be ready to troubleshoot. And how do you do that? You might need to revisit the diagnosis with more images or more lab tests. 2, you might need to expand your treatment, like broadening the antibiotic coverage. You might need to seek a second opinion with your colleagues, or even consult specialists like the pulmonologist, the infectious disease cardiologist, or other specialties so you can get their expert opinion. Now, stage 4 is the readiness for discharge. You need to establish treatment goals earlier on in admission. For instance, someone coming with pneumonia or heart failure, you might tell yourself that once oxygen is weaned off, they should be ready to go. If they are vomiting, maybe once they can tolerate PO, or in infections, once the culture results are available. 2, you need to review the disposition plan with ancillary staff. Case managers are involved, physical therapists, occupational therapists, the social worker. As early as possible, you want to start discussing the disposition plan. Some might need home health. Some might need to go to a skilled nursing facility. Some might need to go for short-term rehab. And so you want to start discussing this earlier on so there is no delay in discharge when the time comes. And of course, you want to make sure you're discussing these goals and disposition plans with the patient and the family as early as possible. So in summary, the management summary for admitted patients, we start with phase 1. The patient presents with symptoms. Your phase 2, you obtain symptom-directed history and physical exams. Phase 3, you generate differential diagnosis based on that. Phase 4, you order focused lab tests and images to confirm your diagnosis. And once you confirm the diagnosis, you go to stage 5, which is initiating your definitive treatment plan and supportive treatment plans. And then you go to your phase 6, being ready to troubleshoot if the patient is not responding to treatment or if there are complications that develop while they are in the hospital. And of course, your phase 7, you need to establish your treatment goals for discharge and disposition planning. So this is really what we do. Patient comes into the hospital, you figure out what's going on, you manage them, and you're ready to troubleshoot, and then you discharge them from the hospital. This really is a summary of what we do in the inpatient setting. And so I wish you all the best, whatever you are, whether you're a medical student, a new provider, or a mid-level provider. I hope this is helpful for you to navigate the hospital medicine. Thanks.